back to Lungcast, the monthly respiratory health podcast series from the American Lung Association and medical news site HCP Live. I'm your host, Dr. Albert Rizzo, Chief Medical Officer of the American Lung Association. Before we begin our second episode of 2023, we'd like to remind you that Lungcast is now available on YouTube, as well as all major podcast platforms. You can subscribe to @Lungcast on YouTube to listen to our archived episodes, as well as new episodes and interview segments when they go live this year. A link to the show page, as well as the American Lung Association and HCP Live homepages for Lungcast, can be found in each episode description. You can subscribe to Lungcast on Spotify, Apple Podcast, and your favorite listening platforms, and you can register for more respiratory news and insights at both lung.org and hcplive.com. We're ramping up to some interesting topics and maybe even some shows on the road in 2023. So stay tuned for all we have coming up. Today I'm with our colleague, Dr. Ravi Kalhan, Deputy Division Chief of Pulmonary and Critical Care Medicine at Northwestern University. We're going to get into some core level discussion on the modeling of respiratory health and pulmonary mechanisms, as well as the bolstered role of screening in lung cancer, and also talk about the start of a major new study designed to further inform us on the state of respiratory health and the development of respiratory diseases. Dr. Kalhan, thank you for speaking with me today, and thank you for your work with the American Lung Association. I know you are one of the key principal investigators in an important American Lung Association cohort study, and I would certainly like to circle back to that a bit later. First, I wanted to give you the opportunity to talk about the concept of respiratory health. You and several of your colleagues published a perspective in the American Journal of Respiratory and Critical Care Medicine several years ago, I believe in 2018. In that article, you offer a conceptual model of respiratory health. You point out that respiratory health is often defined as the absence of respiratory disease with no intermediate state of impaired respiratory health, and then go on to compare that to the definition analogous to one in cardiac health and disease. Can you please explain to our listeners the model you are proposing?
Yeah, well, thanks for having me, Al. It's really great to chat with you about this. This is this concept of impaired respiratory health is predicated on the notion that you and I and every other lung doctor from time and eternity has defined disease by physiologic impairment. So we have always used pulmonary function testing as our key definition of COPD, for example, whereby if someone crosses a threshold of abnormal lung function, in that case, the forced expiratory volume in 1 second to the vital capacity ratio being less than 70%, then you have obstructive lung physiology and you have COPD. But that might happen, just take, for example, someone could cross that threshold at age 57. We then behave as if that person had blown into the machine when they were 50, 45, or 40 and did not have lung function below that threshold, that they were normal. But of course they were not normal. They didn't wake up one morning and develop chronic lung disease. It went through a progression across their life course. And by ignoring what we term the intermediate phenotypes of what someone looks like as they transition from ideal respiratory health, as good as they get in their early 20s perhaps, to chronic lung disease, we eliminate the opportunity to intercept the process and actually change the public health. On an individual level, it's really, important to define disease. On a public health level, it's really important to think about these intermediate impairments so we can actually try to intercept. Cardiovascular people have, in fairness, more information than we do in their ability to do this. But when they say in primary care, we should check cholesterol, it's because an elevated LDL cholesterol is an intermediate phenotype of impaired cardiovascular health that is on the pathway towards atherosclerosis and heart attacks. Now, they were afforded through studies like the Framingham Heart Study, started in the 1940s, with a longer time period than we have to figure this stuff out. But that conception of the intermediate phenotypes, high cholesterol, high blood pressure, physical inactivity, those intermediate phenotypes inform disease interception and health promotion such that the burden of heart attacks goes down in society. And we need to think creatively in the respiratory space about how to do that. And that's sort of the fundamental thought behind that framework that we presented in that paper.
Well explained. And in that paper, you go on to point out two concepts that help explain this model: pulmonary reserve as reflected by peak lung function, and susceptibility as reflected by risks for future accelerated decline in lung health. Can you go on to explain the pulmonary reserve first?
Yeah. So when we say pulmonary reserve, what we really mean is peak respiratory health, if you will. It's the amount of capacity and resilience someone requires sort of through their early life. So some kids are born premature. We know that kids that are born premature are at risk for lower peak lung function in young adulthood. They have less reserve, if you will. We know that children born in houses where there's lots of secondhand smoke, grow up in houses with lots of secondhand smoke or other airborne pollutants, gases, vapors, fumes, are probably susceptible to those fumes in the sense that they acquire less peak respiratory health. That's not necessarily been proven in a bunch of studies. There's a number of studies that I seem to hint at that notion. What about kids who get RSV in childhood? Does that lead to a lasting impairment such that they have lower reserve? They have lower peak lung development in young adulthood. So if you have lower peak development in young adulthood, i.e. your starting point is lower than someone who has ideal growth throughout their life course, then you're at a disadvantage. And even if those people don't have an accelerated rate of decline in lung function, even if those people don't smoke cigarettes, even if those people don't work in a factory or a mine or have other exposures with household cleaners or hair chemicals, those folks are perhaps at a disadvantage compared to people who have higher lung function. And what can we think about for those people to enhance their resilience such that they don't experience chronic lung disease in the future based on what happened to them or what they were exposed to in their growth period throughout childhood and young adulthood?
So that goes on to the susceptibility part of the model. Once the peak lung function has been reached, then they are susceptible to decline based on the discussion you just gave us. Is that correct?
That's correct. And some people are susceptible and some people aren't. I mean, we don't know to this time why someone who smokes a ton of cigarettes in their life may or may not develop COPD or emphysema or lung cancer. Some people, for whatever reason, are resilient to those things. Other people are highly susceptible and their lung function declines. Now, if you have low reserve and you're susceptible, then that's the highest risk group in our framework.
Very good. You may have touched on this next question a little bit earlier. In the absence of any specific biomarker for respiratory health, we are at a disadvantage. You mentioned the cholesterol that cardiac disease has been benefited from. And you go on to say that there are some surrogate markers for respiratory biomarkers that were seen in the cardiac cohort study that can reflect some lung decline. Can you just comment on them a little further?
Yeah, so those, Cardia is a study that I've worked on for a number of years, where we've been afforded the chance to do a lot of lung measurement in this cardiovascular cohort. Cardia was started in 1985 in the United States among 18 to 30-year-olds. So it's advantageous in the sense that's what we think is the time of peak respiratory health, sort of the mid-20s. And spirometry was done in Cardia, so there's some lung function. And cardiac CT scans were done, and we've been afforded the chance to look at lung function decline in Cardia and the risk of future emphysema and COPD. In Cardia, there are some biomarkers that are associated with future lung disease. They're kind of generic. They're measures of systemic inflammation, like C-reactive protein in young adults, or endothelial dysfunction, like ICAM1. It's stuff that it makes sense that it reflects a vulnerable population. But the concern that it brings for me is that it's a vulnerable population that's prone to systemic inflammation. But we're not clear that CRP is on the causal pathway to lung disease. Cholesterol is so good because you can measure it easily. It predicts the outcome of heart attack, but it's also on the causal pathway for atherosclerosis. Cholesterol plaques form in arteries, which create atherosclerosis. And there are then pharmacotherapies with statins and other drugs that lower cholesterol and lessen the risk of plaque formation, which lessens the risk of heart attack. That's where I want us to get with lung disease, is there's something that we can target to intercept the process specifically, not just sort of know that people who are prone to systemic inflammation are at risk for future disease. I think that's a great starting point. And I mean, I'm biased because I wrote one of the papers or two of them, but it's not the answer. It's not where we need to be.
This next topic, I know you and I have discussed in the past, is the CT scan imaging acting as a possible biomarker for susceptibility to lung decline. We know that many of the low-dose CT scans done for lung cancer screening are finding evidence of emphysema in individuals without any respiratory symptoms, but certainly at risk in view of their smoking history. Do you think there is a role for this finding to be reported in some manner that would alert the clinicians to potential interventions to delay lung decline, such as stronger efforts at smoking cessation in those that are still smoking?
Yeah, I mean, I think CT imaging is part of the answer here, and it's reflected through a couple of things. One, yes, the detection of people who are early in their course or haven't reported symptoms or have never done a breathing test, and identifying those people and thinking through the best treatment, smoking cessation being the highest priority, but then also performing a pulmonary function test in those folks and figuring out if they meet the clinical definition of COPD and applying treatment to reduce their future burden of exacerbations and improve their quality of life and sustain it in the long run. We can detect early pulmonary fibrosis on those same CT scans. You know, pulmonary fibrosis smoking's a risk factor for pulmonary fibrosis. It's shared with lung cancer, and early application of antifibrotic treatments in people with idiopathic pulmonary fibrosis, at least, is an important therapy. I mean, that's an underdetected disease, and early therapy probably helps. So I think in the screening population, there's a huge opportunity to pick things up. There's also sort of a more novel thought around CT scans that my collaborator, George Washko and Raul San Jose, who we work closely with, you and I both work closely with, have developed a number of CT metrics that, using novel machine learning methods, can detect the earliest forms of lung injury. So someone gets a screening CT and they may have, you know, if they're fortunate, they don't have any emphysema, fibrosis, or nodules. But if we could apply a novel algorithm that assessed regionally whether they have lung that is injured or susceptible to future problems, then that is perhaps a group that we could target for interception. We're not there. We need to study CT scans in a longitudinal fashion. We just did this in cardio. We have over 1,000 people who had a scan 10 years after another scan. So mean age 55 and then mean age 45 and then mean age 55, and got 2 scans separated by 10 years. And we can really start to think about whether early lung injury predicts future problems in that cohort. And then I think that will empower the thought process behind how we view CT scans to not just detect disease, but detect risk of future disease.
Quantitating it, right. Very good.
Yeah.
The last topic I'd like to address is the American Lung Association's Lung Health Cohort study, funded by NHLBI and being run through the ALA's Airways Clinical Research Centers. Can you explain what the study is and what is being monitored? And based on the discussion we just had, how do you see the long-term results of the study playing a role in defining respiratory health?
Yeah. So the Lung Health Cohort, the ALA LHC, as we call it, is a study that we initiated. Now, it was delayed by COVID, so 18 months ago now is when we got our first participant in, or 15 months ago, something like that. And it's a study that is community-based, meaning we just want people who live freely and have nothing wrong with them, between the ages of 25 and 35, to come enter a long-term cohort study. So a cohort study, the definition of a cohort study is we take a population that meets certain criteria. The criteria for the lung health cohort are your age is 25 to 35, and you don't already have chronic lung disease. We pick that age range because, as we talked about before, that's the age of peak respiratory health. We want to capture adults at their best. Some of them may have lower reserve. Some of them may have, high reserve. Some may be highly susceptible. But what's really important about it, Al, is one, it's a lung study. Like everything we've done in cardia is us trying to reverse engineer information from a cardiovascular study. The goals were our cardiovascular. The goals of this study are around lung health, and our phenotypic assessment is related to lung health. Spirometry, a lung CT scan, a discovery biomarker approach that includes sampling of the nasal respiratory epithelium, the nasal lining fluid, as well as the blood, and an ascertainment of exposures and behaviors that we think are important to respiratory health. So vaping, smoking, physical activity, but really importantly, also where someone has lived from birth till now. And then geocoding very specifically those addresses so we can estimate their exposures to airborne pollutants. Maybe in the long run, we can add exposure to airborne allergens and other things that we think influence respiratory health. So we're going to do a baseline assessment of these people with scientific goals of understanding the determinants of peak respiratory health. That is to say, all these life course pollution, pollutants, physical activity, behaviors, does that influence this concept of reserve, the peak respiratory health someone attains in young adulthood? And then in addition, figure out whether people who have lower pulmonary reserve in young adulthood, someone who has lower lung function than someone else, for example, whether that translates to abnormalities on CT scans to really understand what's going on with them and see whether it translates to a different biomarker profile so we can try to understand exactly what's happening. Then, and we're going to have to get more funding to do this, we want to conduct basically what the Framingham study has done for cardiovascular disease for respiratory health and follow these folks the rest of their lives to really understand how this evolves across the life course and identify targets to actually intercept chronic lung disease before it's clinically apparent, i.e., determine what could be the cholesterol for the lung, if you will. It's probably not going to be a single blood measure, but figure that out and then create a platform where we can actually test therapies. We should stop talking about the cholesterol for the lung, Al, and we should start talking about the statin for the lung, but test therapies that can actually stop the progression towards chronic lung disease.
Right. Important study, and you explained it very well. I know there's also several sub-studies or what's called maybe ancillary studies being added to this cohort. Any chance you can comment on some of these and their role in moving the science forward?
Yeah, some are really compelling. The one that comes most to mind, of course, based on our experience, our shared experience as society over the past 3 years, is one that the ALA funded related to COVID-19. We really are trying to understand how COVID-19 infection impacts respiratory health in young adults. And it's super interesting. One of my fellows, Amy Ledwig, is really on the chase about this and trying to figure this out. But it's really interesting in that, most young adults did not end up in the hospital with a COVID-19 infection, fortunately. But they got sick, they got a virus infection, and then we don't really know what that does in terms of sort of their lung structure, how they feel sort of if you measure symptoms with a detailed questionnaires, not just sort of how you feel in clinical stuff, but like really measure stuff. And then we don't know what their biomarker profile could be, these versus someone who did not get infected with COVID-19. Now, it's a little tricky because lots of people got infected with COVID-19 as the Omicron variant emerged and things like that. But fortunately, we have time course and we have information about people self-reporting their COVID illness and when they got it, when they got vaccinated. And then with the help of the ALA, we'll actually do antibody profiles to sort of sort through who has antibodies against the nucleocapsid versus the other proteins on COVID-19 and how we can understand what looks like an infection versus vaccination and stuff that will allow us to really sort this out. But it's sort of interesting because it'll let us understand what we think is unique about COVID-19, but then people get respiratory viral infections. It's part of life. Some people get more respiratory viral infections than others. And some people seem to be highly burdened by respiratory viral infections. I mean, Al, you and I have had patients forever who seem to get bronchitis once a year and require medical attention for it, whereas other patients, they catch a cold and they move on with life. And the opportunity to actually study that and understand that as a risk factor for future illness is really important and interesting.
And dare I say, I know we didn't use the term, but long COVID or these chronic symptoms, certainly pulmonary is among them. I know fatigue and brain fog are up there as well, but I think the same population, we should be able to learn about that as well the longer we follow
Absolutely. Them. And I think it'll let us ask sort of careful, detailed questions about the respiratory symptoms, because as you know, in clinical practice, it's one of the shortcomings of our specialty in some senses is we don't really ask systematic questions all the time. We ask, are you short of breath, or are you coughing? And that may not be true one day, but might be true another day. And it's sort of it's not a way to sort of really capture the scope of symptoms. And I'm optimistic that when we ask careful questions, we'll be able to really get granular on the longer term respiratory impacts of something like COVID-19 infection.
Well, I want to thank you for your time today, and wish you luck with all the good work you're doing in respiratory research. For our listeners who want to know more information, certainly the American Lung Association website at lung.org can be helpful. The overall state of chronic lung diseases has been covered previously on Lungcast, so anyone who wants to learn more should check out our asthma episode with Dr. Mario Castro or our COPD discussion with Dr. Malon Han. Be sure again to subscribe and rate Lungcast on your preferred listening or watching platform, and visit lung.org and hcplive.com for more news and resources. Until next time, I'm Dr. Albert Rizzo. Remember that if you can't breathe, nothing else matters.